Onc Live Insights is a video editorial program produced by Onc Live.
One of the biggest questions that we have is how to sequence therapy and how to maximally use all of our current therapeutics. And so one of the challenges is that how do you use all of your therapies currently in this day and age? And so currently there's really two pieces of data that we've kind of relied on. And one is when we look in subset analysis from randomized controlled trials, and we look at patients' prior lines of therapies, that typically doesn't impact some of our novel therapies. And so regardless of what your last line of therapy is, you're going to get an equal benefit to some of our newer therapeutics. That's one piece of information. The other one is a recent study, I believe the MM13 study, which looked at the use of pomalidomide right after lenalidomide progression without an intermediate proteasome inhibitor. In the trial, that in fact showed that the response rate with pomalidomide and low-dose dexamethasone was 30%, which is what we've seen in other settings with pomalidomide. Given that there's no other randomized clinical trials that answer the question of how to best sequence therapeutics. Historically, we normally would recommend alternating IMiDs and proteasome inhibitors, and that's what we've done in practice. And this is based in part on our clinical practice, but also understanding the clinical clonal ties in evolution in the biology of the myeloma, where we'll alternate therapies. And ultimately, what we recommend, as long as the patient gets exposed to all of your novel therapies with your proteasome inhibitors and your IMiDs, then the patient will have the maximum benefit from those. I think in the future, as we move forward and talk about sequencing, it's going to be important to really think about strategic sequencing in that setting. And that means how do you maximally leverage all of our therapeutics? And so not just thinking about what we're going to use for this line of therapy, but what am I going to use in step 2 and step 3 at second and third and fourth relapse, and trying to think one step ahead to make sure that we maximally use all of our therapeutics and get the best benefit for each one of them. So I think it's going to be important as we move forward, not to think that we have lots of options, and I'll worry about that later, but to really kind of think one step ahead and say, how do I use all of my drugs and what's going to be my next step?
Now in Europe and in Spain, the logical sequencing is bortezomib-based, the combination in the upfront setting, because they are approved. And in transplant candidate patients, they usually receive a 3-drug combination. In non-transplant candidates, they usually receive the bortezomib plus melphalan and prednisone, or bortezomib plus thalidomide and prednisone or cyclo. And the second line is usually an IMiD. It's important to note that a few patients can receive a retreatment with bortezomib in the second line of therapy, but physicians tend to switch drug class, and it's common to use lenalidomide plus dexamethasone as a 2-drug combination. At the third line, as I have previously said, probably the optimal approach is to choose between retreatment with bortezomib-based combination or to move to the second generation immunomodulatory drugs such as pomalidomide. However, this scenario probably will change in the near future because lenalidomide plus dexamethasone has just been approved here in Europe in the upfront setting in non-transplant eligible myeloma patients. And in addition, many physicians are going to use probably lenalidomide as part of the maintenance therapy. So patients are going to receive lenalidomide in the upfront setting, and this is going to influence the option of therapy at the moment of the first relapse. And patients usually should receive bortezomib-based combination or proteasome inhibitors. And as in Europe, carfilzomib is not approved yet, probably bortezomib-based combination would be used also in the second relapse.
The choice of sequence really is driven by a number of factors. In young patients, I think that the evidence suggests that we use a proteasome inhibitor-based induction. I think the evidence for that really is reasonably sound. I would then use high-dose therapy, and then my routine would be to introduce an immunomodulatory agent then at that point to consolidate the response, so that I've used 3 different interventions to try and maximise the depth of response. So proteasome inhibitor, high-dose alkylator, then IMiD in that sequence. In elderly patients, my consideration as to what order to use drugs is often driven by other considerations. It's possibly driven by the geographical circumstances, for example, of the patient. So if I have an old patient who lives a long way from the treatment centre, I may be more inclined to use an IMiD-based induction, which is oral, and therefore minimise the implications for the patient in terms of travel for treatment. If I have a younger old patient or one who's more robust or motivated, I would probably again go with a bortezomib-based approach and then move on to an IMiD at first relapse, or vice versa in the patient in which I'd used an IMiD first before whatever circumstances.